All right. This week, we are talking about muscles of the trunk and the joints of the spine. We've got several muscles that we need to cover. Let's get through these reviews. Make sure you take the midterms. Do this Thursday by 2:30. All right. So bones of this area, we have 7 cervical vertebrae. We have 12 thoracic vertebrae. We have 5 lumbar vertebrae. I don't know if I've ever given you guys my little trick to remember those. But think about your meal times. You eat breakfast at 7 and you have lunch at noon and dinner at 5. And when you add them together, there are 24 hours in a day. There's 24 vertebrae total. 12 pairs of ribs. We have true ribs, false ribs, and floating ribs. Let me see if I can switch us over to true ribs. Are like the first 6. They truly connect to the sternum. They swing around and plug straight in. The last true rib you get is rib 7. Ribs 8, 9, and 10 do not truly connect to the sternum. Their cartilage fuses with the cartilage trunk of rib 7, so they do not directly attach. They are false ribs. Ribs 8, 9, and 10. Ribs 11 and 12 do not even attempt to connect to the sternum. They stick out like a diving board from the spine. Those are floating ribs. Floating ribs are ribs 11 and 12. All right, and pelvis, anterior superior iliac spine, the ASIS. If you put your hand on the front of your hip, that's the part of the hip bone that you're feeling. It's the most prominent, bumpiest part. Pubic tubercles will sit behind the pubic hair. So if you push down on the pubic bone and kind of rub your finger side to side, you'll feel 2 small bumps on either side of the midpoint. The inguinal ligament. Let me throw some landmark highlights on here right quick. Bam. So there's the iliac crest, and this most prominent bump in purple is the ASIS. The pubic tubercles will be located on the superior aspect of both of your pubic bones. And the inguinal ligament connects those 2 structures. Where's my inguinal ligament?
Hey, Dave.
Yes.
The slides for week 5 lead me to week 4. Like week 4 has been posted twice, so the week 5 slides aren't on Moodle. Just wanted to let you know.
Thank you for bringing that to me. I will fix that today after class.
Thank you. All right.
No, I didn't realize that. Thank you. So I'll just isolate this ligament. There it is. From the ASIS to the pubic tubercle, that is the inguinal ligament. Joy, can everybody hear me?
I can hear you.
Okay.
I can hear you.
Yes.
Okay, cool. Joya, I guess it's just you. All right. All right, sites of caution, things you want to be aware of. First thing, immediately on the other side of the floating ribs, right on either side of the spine in the thoracolumbar region, sit the kidneys. They sit between T12 and L3 on either side. So when you're applying firm pressure, just be aware if they are a little bit frail or fragile, if they have osteoporosis. You don't want to put too much pressure on those floating ribs. Those ribs can break and puncture a kidney. So you can use pressure. We just have to be cautious of it. And About 2 inches above the belly button. If you press into the abdomen, you can feel a strong pulse. That is from the abdominal aorta. So let me add in blood vessels and then hollow this stuff out so we can see that extremely thick red trunk running along the spine is the abdominal aorta. It is continuous from the aorta above. Let me thin this out a little bit more. Sorry, that was a bit much. You'll see the aorta exits the heart. It turns posteriorly and then drops straight down along the spine to carry blood down into the internal organs. Abdominal aorta. You can feel its pulse. It is very large, so don't push too hard. You don't want to put a lot of pressure on arteries. That tends to obstruct blood flow. Oops. All right. Conditions you are likely to see when you're working on the spine: kyphosis, lordosis, and scoliosis. All of these are types of curvatures of the spine. A kyphosis is an exaggerated kyphotic curvature through the thoracic spine. We call that hunchback. Lordosis is an excessive lumbar curve through the lumbar spine. So it looks like the upper back is really pushed far back, as so are the hips. So the low back curves a lot. We call that Instagram booty. Scoliosis is a lateral curvature of the spine. So when seen from the front or back, it should be straight. Scoliosis is a lateral curvature. All of these can be implicated in low back pain, as can disc herniations, and we will look at those in just a few. So here's your image of hyperkyphosis. It's a hunchback. Sorry, I just want to catch up on the chat. Yeah, I'm sorry, Joy. Yeah, I'll definitely get the recording posted today. Yeah, I'm sorry you can't hear. There's the lordosis. So if you check the right-hand picture, right, it looks like he's posing for a picture on Instagram. And scoliosis. Notice how the hips and the shoulders are offset from each other, almost like a typewriter. Scoliosis is ultimately caused by an actual rotation of the vertebrae. And since they all interlock with each other, when one vertebra is rotated out of place, it's going to create a curve in order for that to kind of balance itself back out. And so all of this contributes to low back pain. You know, humans like to think of ourselves as like the epitome of evolution, but I'm here to tell you, from an evolution standpoint, we stood up on 2 feet way too fast, and our lower back was simply not designed for it. Our lower back was designed to walk on 4 legs. And so what ends up happening is, get rid of the blood supply. You notice how the entire upper body, all the weight of the upper body is basically leveraged right on those lumbar vertebrae. That's like almost half of your total body weight is compressing just those 5 lumbar vertebrae. That's a really inefficient design. We probably should have had a lot more support, but you know, no one consulted me for this job. Disc herniations are another consideration. The one you're looking at here is at the very bottom, right there. Notice how it is bulging backwards into that light gray strip. Can I do a little laser pointer? Right there. This little strip right here, that's the spinal cord. So that's supposed to be nice and free to move around in its little sleeve and not really get too much pressure. And we see right there, the disc is bulging posteriorly and putting pressure on the spinal cord. Now that is going to be extremely painful. Fun fact, this one is also herniated, but that one probably is causing no symptoms, no pain, no nothing. As long as the bulge let me give us a little drawing here, terrible drawing. So there's the spinal cord. If the bulge is anterior or anterolateral, you really won't notice any symptoms. It will be herniated for sure, but there's no pain, no loss of range of motion, no real symptoms. But if it starts bulging posteriorly onto the spinal cord or posterolaterally off of all of those accessory nerves that are branching out of there, that is what gives you nerve compression syndrome. And that's what will cause all the symptoms, the pain, the numbness, the tingling, all of that fun stuff. Now the question is, can I clear? All right. So movements of the spine. All right, we're thinking about the spinal cord here. We have flexion, which is like leaning forward, extension, leaning backward, lateral flexion, leaning to the side. Keep both feet on the floor when you do that. Ipsilateral rotation. Now we are talking about the muscles. What side is the muscle on? And does it create rotation to that same side? Or contralateral rotation, where a muscle on one side of the body causes rotation to the opposite side of the body. So ipsilateral and contralateral rotations, what those are telling you is where the muscle sits, not what direction the movement is, right? Like medial or lateral rotation. Pelvic tilt. Ooh, this is always a really fun one. So there's a person and they're facing front, and notice the pelvis is like a bowl. And if this bowl was full of water, like to the brim, that water would not be spilling out. That's a level pelvis. With anterior pelvic tilt, the pelvis is tilted anteriorly. So you would be pouring water out of the front of this bowl, which means now the person does not look so happy. Let me get some different colors in here. Let's say red. So now the lumbar muscles, look at how that lower back is really curved now that the posterior spine has been lifted up. The lower back has to curve, so those muscles are shortened. And the hips, since the hips are rolled forward, that's kind of like hip flexion. So the hip flexors are also going to be shortened. So as these two sets of muscles are shortened, their antagonist muscles are now being overstretched. So our hamstring group, right, and the abdominal group, these guys are going to be lengthened. So as the posterior side of the hips is pulled upwards, the hamstrings start getting lengthened. This lovely condition is called lower crossed syndrome. Lower crossed syndrome. There is a similar syndrome called upper crossed syndrome that happens with the neck and shoulders. So as the head is pulled into flexion and then the lower traps get overstretched, the same kind of deal from like working at a computer too much. Now, a little bit less, I don't want to say less common, but a little bit less common is a posterior pelvic tilt. And with a posterior pelvic tilt, you see the same pattern, but this time, since the pelvis is rolling in the opposite direction, those muscle groups are switched, but it's the same pattern. So here, if you see the front of the pelvis is being pulled upwards, so now the abdominal muscles are shortened as the posterior pelvis is rolled downward. The hamstrings are also shortened.
Hello. Hey, Ryan. Hey, did you tell Selena to go to Terwilliger?
Can someone mute themselves, please?
She's here.
Oh, you're there too?
Yeah.
Oh, perfect.
Can someone mute themselves,
All right,
please?
never mind. I just
Yeah,
saw
I'll
it.
send you time cards here shortly.
Okay, cool. Yeah, I just saw this email from
Hey,
Grant.
Guys, I'm hearing
That's
someone's
not
conversation. Can you
where she
mute
was,
yourself,
but
please?
I guess she's accounted for. Thank you.
Yep.
All right, that is all. All right, bye.
Okay, so if the hamstrings and the abdominals are both shortened, now your lumbar muscles are lengthened and the hip flexors are lengthened. And with lateral tilt, think about like standing all sassy with one hand on your hip, one hip is elevated more than the other. All right, so muscles for today, we have the erector spinae group, the famous QL, quadratus lumborum, rectus abdominis, the washboard abs, internal and external obliques, and transverse abdominis, the obliques, and the abdominis pairs. Those four muscles are the abdominal group. So there's one whole group of muscles. Intercostals and the diaphragm. Lots to cover today. We will start with, other structures, abdominal aponeurosis and the thoracolumbar fascia. I think we're pretty much familiar with these by this point. I would hope so. The abdominal aponeurosis is it's all the white stuff on the abdomen, all the flat tendons that all these muscles are attaching to. Same deal on the posterior side. The thoracolumbar aponeurosis is the flat sheet-like tendon where your lats and the glutes and all these things are kind of bleeding into. The linea alba. That was one more thing I meant to point out. Sorry. Linea alba. Come on. There we go. The central line, it's a fibrous band akin to a tendon. It connects from the xiphoid process of the sternum to the pubic tubercles. Xiphoid process of the sternum to the pubic tubercles. That is kind of the main tendon that's being pulled when we go into flexion of the spine. So we pull the sternum down towards the pelvis.
Hey,
all right.
Dave.
Yeah.
Sorry. How deep is that? Like, how deep is that?
Not deep at all. It's not deep at all. It's rather superficial. If you can feel your washboard abs, that's the central line between the washboard. It's right there on the surface. I mean, let me be clear. It's going to be deep to like the adipose tissue around the abdomen, but it's flush with the rectus abdominis muscle. So if you can feel your washboard ab muscle, then it's the midline.
Got it. Cool.
Yeah. All right. So the erector spinae is a group of muscles. These extend from the sacrum and the ilium all the way up to the occiput in some cases. They help you maintain an erect posture. So these muscles are called spinalis longissimus and iliocostalis. I do not want you to remember them this way. First things first, I want you to understand what these muscles look like so we can start to take some guesses as to what they do. They are deep, so I've got to remove a lot of muscles in order to get to them first. So we take away traps and lat dorsi. And now you can see them kind of under that sheath. We've got to get rid of serratus posterior and rhomboids. And serratus posterior superior as well. Now we'll get rid of this thoracolumbar fascia. And there, finally, are the erector spinae muscles. With my kinesiology brain, there's two things that I notice immediately about these muscles. The first thing is that they are on the posterior side. The second thing, those fibers run vertically. Vertical muscles will tend to do flexion or extension. Since these muscles are posterior, that tells me extension. Yes? Yes. So muscles named the erector spinae group, they keep the spine erect by pulling the spine into extension. These are going to be postural muscles. These guys will engage in low grade isometric contractions, low strength isometric contractions for long periods of time to help you stand upright. So as you're sitting or as you're standing, these are the muscles that are just holding you erect. Now, as we said, there are three muscles in this group. Let the names tell you what they are doing. The first I want to talk about is iliocostalis. There's several pieces. So you've got iliocostalis lumborum, that's the part that's in the lumbar. Then iliocostalis thoracis, that's the one in the thoracic region. And to isolate them, first of all, look at all those little end points. This one runs iliocostalis. It runs from the hip to the ribs. From the hip to the ribs. The next one is longissimus. Longissimus it's not going to give me a bone, man. Anyway, take my word for it. Longissimus inserts on the mastoid process behind the ear. So it runs all the way up to the occipital bone. It crosses from the hip to the ear. That is a very long muscle, longissimus. So we have iliocostalis from the hips to the ribs. Next, we have longissimus, the very long one that inserts on the ear. And next, we have spinalis, which is the closest in hugging the spine. The long belly of this muscle rests in the lamina groove. So all those lamina grooves along the spine, those tracks are kind of laid with the spinalis muscle. So from lateral to medial, we have I love spaghetti. Iliocostalis from the hip to the ribs. Longissimus, the longest one. And spinalis, the one right on the spine. From lateral to medial. Together as a group, their origin is the common tendon that attaches to the posterior sacrum, the iliac crest, and spinous processes, all the way up the spinous processes, T11 through L5. Do not even think about trying to remember all of their insertions because they literally connect to like every rib, transverse process, cervical vertebrae, mastoid process. They insert a lot of places. Their action is when they work together, extension. That's what I can look and tell that muscle. I know that muscle is going to do extension. When one side contracts, lateral flexion. Extension and lateral flexion. And those would be of either the trunk or the neck, since these muscles do cross through the cervical region. And there's the main erector spinning. All right, QL. Get good with this muscle. It'll make you lots of money in your career. QL is one of the two major muscles most often responsible for lower back pain. It originates on the posterior iliac crest. And I'm not going to throw words at you. I'm going to show you where this thing is, and then we'll look at the words. So we got to keep going deep. There's QL. So quadratus lumborum starts on the iliac crest, and it inserts on the inferior margin of the 12th rib and on the transverse processes of L1 through L4. L1 through L4. It does not insert on L5. Looking at this muscle, it is going to be a lateral flexor. So one side reaches up, grabs the ribs, pulls down. That's also going to be a low back extensor. So it's going to pull down on the ribs and lean us into extension. Also, if you think about taking a very, very deep breath in, right? Like staying underwater for just a little bit too long and you finally break through the surface and you we talked about these upper muscles lifting up on the ribs to increase the lung capacity. QL from its position is going to pull down on the lower ribs just to really open the rib cage as much as possible to let as much air in. So through forced inhalation, it will assist with pulling down on the ribs. But its main actions are extension and lateral flexion. QL also has a nickname. Its name is the hip hiker, because when you are standing on 2 feet and you start to walk, before you can take that very first step, one of your feet has to lift off the floor to give you the clearance for that leg to swing forward. So the first thing that has to happen in walking is a hip elevation, and that is QL. That's what QL does. It is the hip hiker because it initiates walking.
Is that called a lateral tilt of the hip?
It creates a lateral tilt by elevating one hip.
Okay.
So now it's tilting. Yes.
Okay. Thank you.
But with being a hip hiker and walking, what I want to point out is the hip elevates just so your foot has enough space to swing across the floor. And then once you put your foot back down, now it's back to normal. Now you're walking. So it's a constant balance of hip elevation when you're walking. So we have lateral flexion, also lateral tilt by elevating one hip, and spine extension. It also fixes the 12th rib, just holds it in place during forced inhalation or exhalation. QL is much deeper than you think it is. So we'll practice some hands-on getting our hands on QL, but it is a little tricky to get to. All right, I'm not talking about other structures. We're going to move on. Transverse abdominis. This is the deepest muscle of the abdominal group. And again, I'm not going to go through its origin and insertion just yet. I want to show you this muscle first. All right. So the abdominal wall is comprised of 4 muscles. There are 4 muscles in this group. Rectus abdominis is the one that you probably are most familiar with. It's the washboard abs. Here you have the external oblique. We'll take that away. There is the internal oblique. And now we're going to take that away. And there is transverse abdominis. Transverse abdominis is trying to tell you what direction its fibers are going in. They are in a transverse direction. They wrap horizontally around the abdomen. So when this muscle contracts, it compresses the abdominal contents. This is the muscle you contract when you suck it in to get in your pair of skinny jeans that you haven't fit into since 1984, and you finally get that button snapped. That's transverse abdominis. And when you let it go and that button pops off, now we know where to place the blame. This is the deepest muscle. Its only action, because remember, it's not attached to any other joints. So when it contracts, it compresses the abdominal contents. It also will contract just to provide structural support. So it's a fixator, if you will. But remember, fixating is not an action, right? It's not a movement that we're talking about. Next is rectus abdominis. This is the famous one. This is the guy that we are all so intimately familiar with, the classic washboard abs. There is a saying in the community that abs are made in the gym, but they are revealed in the kitchen. Meaning the body likes to tuck fat right on the surface of the abdomen. So even if you've got amazing abs, a little bit of extra body fat will pad those out, and so they don't really stand out as much as they should. So you got to work in the gym to get them. You got to work in the kitchen to show them off. These guys, if we look at where they're positioned on the skeleton, they insert onto costal cartilage and the sternum and the linea alba. They insert at the pubic tubercles. So since these muscles are vertical, that tells me they're going to do flexion or extension. They cross on the anterior side. That tells me flexion. So these are going to be spine flexors. When they contract, you lean forward, which is why, what action do you do to work out your abs? Crunches. Yep. Aren't those fun? So origin, pubic crest, and pubic symphysis. Remember, because the origin is the least movable, and we're talking about moving the spine. So origin is down below. Insertion, cartilage of ribs 5, 6, and 7, and the xiphoid process. The action is flexion of the spine. And when they contract, they tilt the pelvis posteriorly. Remember, we just drew our little guy here. Our little guy here. They are shortened during posterior pelvic tilts. And it also compresses the abdominal contents, because when these guys contract, it just squeezes in on the belt. You guys know how sucking it in works. I ain't got to explain it to you. And there they are. There they are. It is quite common for people to have 8. That's usually the number. You're usually just wearing jeans or something like that right about there. So as low-rise pants came into play, you'll notice that's when the 8-pack really became a thing. But when guys wore pants on their waist, it was a 6-pack that they wanted. Culture. All right. The internal oblique and the external oblique. I've got a few notes before we start. But first, the external oblique is called the external oblique because it's the one on the outside. Notice the oblique muscles. First of all, the name oblique means at an angle or sloped. So the name oblique is telling you these muscle fibers run at an angle. And we said muscles that go at an angle tend to rotate something. Since these guys are crossing the spine, they are rotating the torso. Next, external is called external because it's on the outside. If we take this one away, the next muscle is the internal oblique. These two muscles are pulling in opposite directions. So one of them, let me write my notes here, guys. Take notes, write this down. The easiest way to keep these two straight, my little cheat sheet is IRS. Internals rotate same, IRS. Internal obliques are ipsilateral rotators. External obliques are contralateral rotators. So ERO. Externals rotate opposite. Internals rotate same. This one is the easiest one for me to just hold in my mind. So when you ask me, what do the external obliques do? They are contralateral rotators. When the left side contracts, the torso rotates to the right. Since they are on opposite sides, you will also get lateral flexion. And since they're on the front, they will still assist with regular flexion. But the obliques' claim to fame is contralateral rotation. Notice the muscle on the client's left is contracting, but the client rotates to their right. They will also assist with flexion. Pulling the ribs down towards the pelvis. As well as lateral flexion. Again, pulling the ribs toward the pelvis, just using different fibers, pulling in a different direction. Now, internal obliques. Whoa, sorry about that. Internal obliques, same story, we just swap it. Now they are ipsilateral rotators. But they're going to be positioned to do the same thing, lateral flexion and trunk flexion. They're still crossing the joint on the front, so they can do flexion. They're crossing the joints on the side, so they can do lateral flexion. But for rotation, these guys are now going to be ipsilateral rotators. Oh, and by the way, there's spinalis roped up along the spine, nice and pretty. Good stuff, good stuff. All right, so the internal oblique comes off of the thoracolumbar aponeurosis, the inguinal ligament, and the anterior part of the iliac crest. The fibers wrap around and insert on the internal surface of your lower 3 ribs, 10, 11, and 12, and the abdominal aponeurosis at the linea alba. So they come around and insert on the linea alba, which means they stop at the midline. That's where your left and right muscles meet, is the linea alba. Flexion of the spine, compression of the abdominal contents, lateral flexion, and ipsilateral rotation for the internal obliques, IRS. Same actions, except contralateral rotation for the external obliques, ERO. Externals rotate opposite. Good stuff so far.
Great stuff.
Awesome. Oh, one more little detail, just throwing this out there, you guys. Since the internal and the external obliques do rotation, if you really want good abs, crunches aren't really enough. You've got to work out all fibers of a muscle, right? You want really good pecs, you can't just like do one, you know what I'm saying? You got to get all fibers of the pec for the whole muscle to really pop. Same thing for the abdominals. So this is why you do the crunch with the rotation, to make sure that you hit the obliques as well. Also, if you're looking for the V, you know what I'm talking about? The V, you got to get the external obliques. That's what pops to make the top part of that V. Let me see if I can pull up a tasteful photo.
Those things are gross.
Humans have wide tastes on what we consider beautiful, culturally speaking. So I try not to judge. I mean, there's people that put plates in their ears. So I really have no, to each their own is what I say. But here's an example. So you see the washboard abs, that's rectus abdominis, but you see the solid wall of muscles that lead down into the V shape above the band of those are the external obliques. And then I know that this is not super common to see, whoops. Not super common to be able to see, but you can see sartorius on this guy's left thigh, running right from the hip, straight down the leg, wrapping around the knee. You don't get to see definition on sartorius very often. It's usually only on bodybuilders that you'll really get to see that particular muscle pop. So it's one of the quality control factors that I look for in bodybuilder legs. If you can't really see a sartorius, how hard could they really have tried? I'm kidding, of course. Okay. Enough about the V. Intercostal muscles. It's another group of muscles. So again, we're not going to look at individual ones. We're going to look at this whole thing as a group. They all start at the inferior border of the rib above them, and they insert at the superior border of the rib below them. So they literally run between the ribs, hence their name, intercostals. There are two groups of them. You have the internals and the externals. Externals elevate the ribs to help with inhalation. So they pull the superior margin of the rib below toward the inferior margin of the rib above and lift the ribs when we breathe in. When we breathe out, first of all, they relax, but when you continue breathing out, they then pull down on the ribs, compressing the rib cage, helping to push air out. Otherwise, they can contract isometrically to just stabilize the rib cage through the intercostal spaces and just kind of reinforce the strength of the rib cage overall. And I've got to remove several layers of muscle in order to really start to see these guys. And there you have your intercostals. These are the externals. If I remove these, now you see the internals. Notice that they run in opposite directions.
What's the white stuff that's covering the internals when you remove the externals? Is that just like some sort of fascia?
So between the ribs, that's the tendon. That's the tendinous portion where the muscle's plugging into the rib.
No, I mean, so put the external ones back. See by the sternum, there's a bunch of white, and then you remove those.
Yes.
And then you, yeah, what's that?
The external costal membrane, it's more fascia that wraps around the costal cartilage. It also serves as an anchorage place for the muscles to attach to.
But okay, it just goes away. The internals don't have that though, it seems like. Because when you remove
no, just the externals.
Okay.
Just the externals, because they're the ones that have to really contract. With inhalation, that's the active phase of breathing. It takes muscle contraction to inhale. It only takes muscle relaxation to exhale. The weight of the rib cage will settle back onto the lungs to push air out.
Gotcha.
So you need
Thank you.
stronger, you just need a stronger group to lift than you do to pull down.
Cool.
So yeah, and then once I added in the costal cartilage itself, you start to see why it's an entire complex of tissues, just all kind of sewn together here. The costal cartilage, the ribs themselves, the periosteum and perichondrium is just continuous across those. And then you've got, of course, the ligaments that are connecting the sternum to the ribs. And then we're still underneath a lot of other muscles. So pectoralis major, for example, is still stuck on top of this. So the posterior surface of pec major is interfacing with all of this. So there's going to be layers of fascia holding all those together as well. It's redundant. Intercostals. If you've ever eaten ribs, like pork ribs, that's the intercostal meat. That's what you're eating. You have also, if you've ever eaten ribs, you notice when you break ribs apart, there's like 2 distinct rows of meat. That's internal and external intercostals. You've probably seen these before. You just maybe didn't catch what you were looking at, but pay attention next time. Many times when I teach kinesiology, I will have several students that will become vegetarians because I make meat too real for them, I guess, but it really is the best way to learn. Getting your eyes on something that actually works the way I'm walking through the meat department and just looking at the steaks and the cuts that you see, very educational. You don't even have to buy anything, just observe. But if you do eat meat, pay attention and you'll learn a lot about kinesiology. All right, last muscle for today is the diaphragm. This is one of the deeper muscles. Bam, there it is. Look at that distinct shape. I no other muscle shaped like this. If I had to put a name onto this, I would say it's shaped like an umbrella, right? And much like an umbrella, right? If you think about walking around with an umbrella, when you grab the little knob part and pull, the umbrella goes down. And then if you don't make it all the way to the click, if you let it go, the umbrella relaxes and pops up. So we contract to pull it down. This is the way that the diaphragm works. If you notice inside that tendon that's sticking out, that is called the central tendon. That's its name. I didn't make it up. That's just what it is. I'm just reporting the facts here. The central tendon, that is its insertion. Its origin is the xiphoid process and the posterior, or the internal surfaces of all those ribs. You've got tons of ligaments that are attached to it, as well as L1 through L3 transverse processes and bodies. This guy is pretty well anchored. He doesn't slip and slide around, is what I'm saying. Another distinctive feature, if we look at the top, you'll notice there is a quite perfect hole cut out of that muscle. That is the passageway for the inferior vena cava into the heart. Blood's got to get through the diaphragm somehow. So we literally just popped a hole in it and we run a tunnel through it, and that's what we did. If you also ask where the aorta goes in all of this, the aorta plunges underneath on the posterior side there. So the aorta actually isn't really impacted too much by the diaphragm, but there is a distinct hole in the diaphragm meant for the inferior vena cava. Whew, that's a lot of muscles on this first level. And there's your diaphragm.
Can we see its actions?
Absolutely. Um, this one does not have an action. Cross sections, models, origin, insertion, nerves. Nope. It lists all the info for me, but it does not give
But
me
it's like
its
the
action.
coolest one.
I know.
It does the most like non-traditional
I know.
contraction.
Here's the best thing that I can say. You know what? We don't need no lymph. All right, take out all the stuff I don't need. Okay. So the roof of the diaphragm is anchored to the sac that the lungs are contained in. That sac is called the pleura, Pleura, the pleura. We said there is your central tendon, or there's the central tendon. You see the central tendon running down the spine. So when the muscle contracts, just like an umbrella, when it contracts, the umbrella is pulled down, which tugs on the sac of the lungs, pulling down on the lungs. This opens the lung space. So breathing is, do you guys know what a bellows is? A bellows, it's like the paddle thing. You've probably seen one in a cartoon. These little paddle things are used in fireplaces. You open it up, and by expanding it, it pulls air in. So then you squeeze it and it forces air out. And the idea with these things is that you push air into a fire to like fan the fire up. But they give you a strong blast of air because when you pull them apart, you've got this space that's increasing in volume, and now the pressure is dropping versus the air pressure on the outside of it. And nature does not like to have different amounts of air pressure. It's going to try to equalize pressure as much as it can. So when you open it up, air is pulled inside. That's how breathing works. When you pull down on the lungs, the internal volume expands, lowering the pressure. So nature equalizes the pressure by forcing air into the lungs. Then, once you've got a lung full of air, the ribs relax, the diaphragm relaxes and raises up, and that squeezes the lungs, increasing the pressure. So now to balance out the pressure, air is pushed out. And that's roughly how breathing occurs. But you can't really talk about breathing without understanding kind of geographically where the diaphragm is in all of this. So getting a good sense of where it sits in the body helps give you an intuition of how this muscle is going to work. So the diaphragm's origin is going to be on the interior surfaces, ribs 7 through 12, inner surface of the xiphoid process, and the upper 2 to 3 lumbar vertebrae. Its insertion is the diaphragmatic central tendon, or just central tendon. And its action, when it pulls down, causes inhalation or inspiration. It pulls the central tendon downward, just like an umbrella. Good stuff. Any questions?
Great stuff.
All right. It's shaped like a parachute. Yeah, it is shaped like a parachute, but I think the umbrella analogy works a little bit better. Like you pull it down and you let it go and it pops back up. Ooh, there's a cadaver image of it. So like that's really what it looks like. Very, very tendinous. All right. Muscle cards. As the slideshow noted, you do not need muscle cards for the erector spinae group. That is just that's way too much. That's way too much stuff. But QL, the 4 muscles of the abdominal group, rectus abdominis, internal oblique, external oblique, transverse abdominis, intercostals, and diaphragm. 7 cards. Those will be due next week. Please do not forget to take the midterm. It is on Moodle. Your deadline is Thursday at 2:30 when we begin class.
Cool.
Do you mind updating the slides after class?
Thank you for the reminder. I'll get that done. Yes.
Thank you.
All right. Any questions over anything that we have talked about so far today? Any questions at all?
None here. Thank you. That was riveting.
Yay!
Not even kidding.
So are we still feeling good about muscles in general? We're getting a hang for this like contralateral rotation and ipsilateral rotation. Good. All right, guys. Well, if you come up with any questions, write them down and bring them to me in class. Happy to answer them. We did get through the whole lecture, so this week it's going to be touching base about the midterms and how everybody feels about them, and then hands-on looking at trunk muscles. Ladies, please wear a sports bra or something, because we're gonna have to do abdominal moving and stuff. And we're gonna have to touch your belly as you do crunches and stuff. And I know it's weird, but welcome to the world. That's what we do in kinesiology.
Okay, thank you.
My pleasure. All right, I will see you guys Thursday.
See you.
Bye.
Bye. Thanks, Dave.
Bye.
See ya. Thank you.
My pleasure.